Welcome back, warriors and supporters, to another great episode of CWF Presents CRPS/RSD is Real. We are here today with Dr. Austin Harris of NeuroRelief, Ketamine, and Infusion Therapy. And today we're going to talk about his extensive background in his study of ketamine and the different properties it has and how it can treat pain and mood disorders. And welcome.
Thank you so much, Brittany. It's a pleasure to be here. This is obviously a topic, a field, a client population that we're both extremely passionate about and that I'm grateful to be able to offer insights and assistance with regards to. And I think it would be wonderful for those that may not already be CRPS warriors to maybe understand your organization and the struggle that folks that have these conditions experience.
Sure. I am the VP of Operations for the CRPS Warriors Foundation, oversee the big picture of everything. So I get to meet a lot of different resources and learn about a lot of different treatments. Then my most joyful part is being able to share that with others that have this condition. I got diagnosed with CRPS in January this past year, actually. It had jumped to my left leg. I had it for a couple of years in my right hand and didn't know it. My boyfriend also has it. So I was very familiar with the condition due to him having it full body. I was on the hunt for anybody that could relate, had been through some of the scenarios he'd been through. That's actually how I came across the foundation. I never left after that. It's just been really my mission to have everyone's voice be heard more than anything. A lot of the times I feel like these symptoms are so bizarre and extreme that people can't relate. An example would be, it's hard for somebody, especially if they've never, say, broken anything, to associate putting your socks on with extremely painful. Or taking them off, you're taking your skin off with them. When you're taking forever to put your socks on, it can become annoying to the people around you, right? Because they're not registering that. It's hard to have to remind people because you feel like a burden. And the more you lose of yourself, what's taking its place is this illness. Myself and a lot of others tend to identify as this illness just because it's what's taking the place of the bits of us that we used to know. That can be very isolating and debilitating. Along with the pain, I don't personally expect pain-free, but finding something that can help is difficult. That's why this is so important, is finding the doctors that have perfected a treatment or are doing research and trying things that are new and are willing to work with us, use kid gloves if we need them, and have faith that we can get better and give us a little bit of hope instead of slapping that untreatable, incurable stamp on us.
The label. Exactly.
Yeah.
Well, thank you for sharing that background. And just to introduce myself, my name is Dr. Austin Harris. I am the owner and medical director at NeuroRelief, Ketamine and Infusion Therapy in Sherman Oaks, which is a suburb of Los Angeles, California. I have been administering ketamine for one purpose or another for going on over 16 years now. So before it was cool, that first started with my career as a cardiothoracic anesthesiologist. That means that in addition to being a board certified anesthesiologist, I subspecialized in open heart surgery, heart-lung transplants, major trauma, the big, long, dangerous, scary, dramatic types of procedures from the anesthesia perspective. And that background and training is actually quite a bit more diverse and in depth than what most general anesthesia requires. So ketamine was a tool that I became comfortable and familiar with because it is so safe. So you can administer that as an anesthetic regimen or a sedative in patients that are very hemodynamically compromised, like severe heart failure, or someone just is about to get a transplant, which means they're very sick, and you have to do certain procedures during or in the ORs prior to them going to sleep, because once they go to sleep, they're going to become very unstable from a blood pressure, heart rate, that sort of hemodynamic standpoint. And ketamine, as it was first invented actually by the US government in 1962, to treat field trauma in Vietnam. It is extremely safe. So it actually supports blood pressure and heart rate and spontaneous respiratory drive. So it's the perfect tool, and also not just to provide sedation safely, but it actually does increase or support heart rate, respiratory drive, etc., increasing the safety of that patient during the time that it's being administered. It's a incredibly unique and valuable tool, the only thing of its kind, right? It is a category of one dissociative anesthetic. There is no other tool or molecule like it, either natural or man-made, known to mankind. This was what first sparked my interest in it, is simply because of its uniqueness. Going all the way back to med school, I was like, oh, this is really interesting. Then through training, you learn to utilize tools. And that was one that I found to be extremely useful in a lot of situations I saw more often than even other anesthesiologists or certainly other types of doctors. They don't use that. That's not a part of their wheelhouse. As that became incorporated into my own clinical practice, at first in the operating room, I started to find more and more areas where it could be utilized. It's an older tool, so even a lot of the newer trained anesthesiologists don't reach for it very often. They have other things they know how to do better. But you always want the best tool for the job, maybe not the easiest or the most common. I remember back many years ago now, I don't just do heart surgery as a cardiothoracic anesthesiologist, but we also do all the other types of surgery, from the simple broken leg to the appendix removal to spine surgeries. I had found myself the first hospital I actually worked in outside of a training environment as a full-fledged anesthesiologist. There was a new type of surgery that was being done that created a lot of difficulty for management of the patient, a new kind of spine surgery. You know, a lot of folks, they suffer with scoliosis, right? So a curvature of the spine, it's genetic and progressive. At one point, I think it was Medtronic, created a new system for doing these. Normally they would be staged. If there's an 11 level spinal level surgery that all that needs to be straightened, they would do 3 spinal levels, straighten, fuse it, and then the patient would go to recover from that. They would bring them back to the OR a couple of days later, do the next 3 until they had the whole spine straightened with anchors and pins and rods and things like that. And then someone decided it would probably be more cost efficient for the hospitals. And if instead of having these long hospital stays, we could do the whole surgery in one sitting. It's a good thought from a technical perspective, but what about the patient? What about the facilitation of that surgery and the recovery from it? That's a significant operation to do all that in one sitting. And they were finding this extremely difficult. Looking at, was very excited about being a landmark site to do this. And they brought in some surgeons that had just trained on this technique. And they were like, we're going to do this. We're going to be the best at it. No one consulted the anesthesiologists. And as they started to do these procedures, it was creating a large amount of complications because the post-op management of the patients from the procedure was looking impossible. Here you have patients who usually are severely progressive in their disease, and so they're extremely disabled. They're usually on multiple high-dose pain medication regimens just to exist, meaning their tolerance to pain medicine is very high. So as they would go into the surgery, we would do what we normally do. But in these patients, they were so physiologically dysregulated. We're doing the anesthesia and we would be giving large amounts of opiates just to keep up with what we were seeing physiologically on the monitors. And then at the end of the surgery, the goal is to have them wake up and take money, right? We would try to wake them up and they had gotten so much opiates just to what we thought control their pain that they weren't breathing on their own. They had to go to the ICU. We looked bad. The surgeons were upset. The hospital was upset. What do you want us to do about it? We then tried to use less opiates, and then the clients would wake up with extreme pain. No one seemed to really be wanting to look outside the box. I stepped forward and I said, we've got to do something here. I designed a basically ketamine only anesthesia protocol that we might try in these patients because we already knew ketamine has the ability to reset opioid tolerances to a lower level and simultaneously work in a different way to control pain and facilitate anesthesia. So it's a trifecta. Always remember the first client we tried this on at the end of the surgery, woke her up and everything was calm. She required almost no opiates during the surgery, which was very strange. And her vitals were very stable, very calm. She woke up in the recovery room about 10 minutes later and just opened her eyes and went, hello, to the nurse that was next to her. And I was sitting there like a hawk watching this patient because I'm like, I don't know what's going to happen here. And nobody else does either. She woke up and it wasn't just that she was pain-free, and she was. She had this huge 11-level scoliosis repair with almost no opiates. Woke up breathing on her own, pain-free, and stayed pain-free. She didn't require a single opiate for, I think it was 48 hours after the procedure. This is unheard of.
Yeah.
No one had ever seen this before. The other thing, and this is early on, right? So this is before people were really popularizing the concept, at least to the lay population, of ketamine's effect on other mood, depression, anxiety, PTSD, things like that. Pain was really its first. Yeah, it was his first primary indication. It was like a different person had woken up before the surgery. She was, to put it nicely, extremely nasty, as a lot of these folks are because they've been suffering so long. She had scared all the pre-op nurses off to one side of the pre-op bay. She was almost unconsentable because they have been suffering so long. It affects all aspects of their sense of identity, as you discussed, their personality structure, their defense mechanisms, their sense of hopelessness. And the person that woke up was like some exorcism had taken place. Seriously. And it stayed that way, right? From the second she woke up, I followed her up maybe once a month for about 6 months. That effect, as if not just the physical pain, but the emotional pain and the effects on her from a neuropsychological perspective, from what the ketamine had done, was long lasting. And this was a revelation to me personally. It speaks to where I come from in all this. I've had a very interesting life. I had a lot of childhood trauma of my own, the depression, anxiety, things like that I'm very familiar with in the past, and chronic pain. I have injuries that I linger today. When I saw this, it was extremely personal. Somehow it made such an impression in me that I became a bit obsessed, for lack of a better
do
word.
something with it.
And it became something that I tried to work in from that point forwards into almost any anesthetic regimen I did as a gift to that person. For whatever reason, they were coming needing anesthesia. I felt I needed to move outside of, you shouldn't have to break your leg to have an opportunity. That shifted into the private sector, outside of the hospital, and eventually to where we are today. But my point in bringing all this up is this has been a journey of exploration. And I think this field of ketamine infusion therapy is very much still in that. Those that feel a personal connection to it are the ones that I think are leading that charge. Sharing that story is relevant to the experience that I think a lot of your CRPS warriors and others out there with chronic pain conditions can relate to.
I agree 100%. Well, when you described when she woke up, it's like the opposite of the transformation. And instead of watching yourself disappear, it's just that person's back. And it's crazy. It was like a reset, just a switch that needed flipped. And she was a whole different person. It's giving me goosebumps thinking about it still.
It was a really beautiful, incredibly inspiring, almost religious experience. I credit that for really being the motivation behind everything that followed.
I can imagine wanting to be able to share that like you said, with other people that are experiencing the same thing. Two is difficult with the mental part of this illness is when people don't understand. There's that expression, you don't get chronic pain until you get chronic pain. They don't understand. They just see somebody who's overreacting, somebody who's angry all the time. They don't understand how it's changing your tolerance level to things around you. And
everything.
Yes, to everything. And it's imagine what it's like to walk through life where everything that touches you hurts you. That hypersensitivity to everything really changes a lot of aspects in life that it's hard to understand if you don't experience it. And all those factors contributing really just make a very lost person.
Of course. And it's our natural instinct from a psychological perspective. And I think this will lead into another aspect of our conversation, that is, what is going on, right? What's causing this? What preceded it occurring? Then what transpires as it's progressing? It is a complex situation. I think it's understandable when someone develops a severe and lasting chronic pain situation, that's going to change you. And just at an instinctive level, right? When we feel that the bandwidth of our awareness is now totally occupied with our experience of pain and our body, and that stimuli that interact with our body seem to be instinctively viewed as a negative, right? As a threat, it creates an entire response such that now we're operating off of ego defense structure and not more of what human beings are normally supposed to operate in about 95% of the time. And that crisis mode, I think people can understand how that can become normalized for someone who's experiencing a lot of both baseline chronic pain, and then when that baseline is exacerbated by external stimuli, they will start to isolate. That wall goes up, they retreat further and further behind it, just as an instinctive avoidance of what is perceived as threatening, painful. And as that occurs, it becomes progressive, right? Because the more we retreat, the less we are then able to get any sense of rewarding sense of self. So depression, anxiety, hypervigilance, emotional dysregulation, that is going to increase if that moment of avoidance becomes normalized, right? We're not able to think joy. That's not a thing. Joy can only occur as a spontaneous, usually surprising, open, thoughtless moment of felt experiencing between ourselves and something that is outside of us, something not us. It's that transference of that moment that creates the joy response. So the more we isolate, the more the joy will become removed, and it's a self-fulfilling cycle.
It's those maladaptive behaviors, and it's hard to break those because they seem like they're helping us at first, because they're putting that wall, like you said, between us and what we feel like is hurting us. But as it goes on, it makes things more harmful than they were to begin with. It's hard when certain things that don't belong there get put in your I need this to survive part of your brain.
Yeah, that survival mode is within us for a reason, right? Going back in time, we needed to run from the lion, hunt the mammoth, fight off the attacking tribe, briefly dissociate in order to process loss, to grieve. But these were always intended to be very short-term states. And neither our mind or our body were designed to sustain that for very long. The way that we're operating societally these days is as if we're constantly under threat. And through news and media and Hollywood, and you have all these very influential things that we're consuming. And I would say we're all operating at a stress level that is far above the baseline that would be healthy for us. And I guess I wanted to state that because I think it's relevant in starting to understand, okay, but how did this happen? How did this one individual develop after they broke their leg? It was repaired. There's no MRI evidence of any nerve impingement. The surgery was a total success from an anatomic perspective. And then suddenly this person is developing CRPS. Why? Right? Why that person and not the other 99.9% of people who got the exact same surgery and had a normal, healthy recovery? I have my way of explaining it, but I also wanted to maybe hand that off to you a little bit. What do you think, as someone who's been experiencing this, that has worked with other people who experience this, what do you notice in terms of folks who present with this, not after it starts, but if you talk to them, what was the approach that you hear about in terms of that internal external relationship, their neurohormonal state, the stress response survival mode versus baseline everything's cool and communion with our environment kind of mode? What have you noticed?
The simple way to put it would be, what's the state of the nervous system when the injury occurs?
Right.
Is it somebody that has been living in trauma? Is it a very traumatic experience? For men that have it, a lot of them were law enforcement, or Brian was a corrections officer. For me personally, of childhood trauma through relationships in my life, I've always said it's funny. The little things make me upset, but when something is huge, I'm shockingly cavalier, because that's my baseline. It always has been. I know that really does play a significant role of trauma, whether it's for an extended period of time or a short period of time, or the incident itself and surrounding circumstances. I don't think I've met anybody that hasn't had something like that. Okay.
Neither have I. And like I said, I've been doing this long enough to have a pretty good sample size to draw that conclusion from. I want to preface this by explaining that I think that folks with central sensitization, because they're very demanding patients for doctors to manage, because they're suffering. But I also think because the sort of establishment, okay, I'm going to either give a drug or give a nerve block. I'm going to do something, and I should be seeing that have the effect that we want in the patient, right? And with central pain disorders, CRPS being one of them, that doesn't tend to be the case, right? The patients are trying, at the advice of doctors, many different things, and it's not working, or it's not working well enough. The established medical model, or I should say the corporate model of healthcare as it's become, is very bad at being able to manage that situation. And the patient may even get labeled or get a vibe that they're being labeled as, nothing what I'm doing as a doctor is working. You're just crazy. It's in your head. You're just, as we say in medicine, you're malingering, you're drug seeking, whatever, as a way to deflect from that provider's own insecurity and frustration that they're not being able to help, and their own ego, right? Or in the corporate model, you're costing too much to try to treat, and so we're going to put you in this other category because we don't want to have to deal with this anymore. And I think it's important that people understand, no, this is not in your head. In other words, the patient is not going, I want my leg to hurt, or I want attention, right?
Right.
At the same time that we can say that this person is truly suffering, and they are, what are other factors that we can look at besides just, okay, this drug I prescribed didn't work? And how can we help that patient to go, okay, this isn't just, though, that you had this surgery and you now have CRPS. A normal thing occurred. That thing then went off the reservation in terms of that person's experience of pain. And there doesn't seem to be a reason why that's happening. Or CRPS type 1, we don't know what started this. There's not even an inciting event from a physical perspective that explains why this person suddenly started having severe pain in their leg, right? There isn't even a start point. So when we look at this holistically, what does that really mean? Holistic means whole person, mind and body. I think it's helpful for people to understand because it's not that they're being judged for the patterns in their life. It's just that we want to understand what that is, because if we do that, then we can address and improve things. And that's actually an empowerment for that patient. Hey, you mean I don't just have to rely on my pain management doctor that I see once every few months to adjust this prescription, but there's other ways of looking at this, and that may be a part of it. But there is the elephant in the room. How is our nervous system, which is both central and peripheral, how is it operating and why? And what can we do about that? And what you described is the norm for folks with CRPS. There's always a story or a period of time that involves what we call in medicine a stress response. And that doesn't just mean I have a lot going on, right? We all have a lot going on. A stress response is a medical term. It means that for whatever reason, the neuropsyche is telling our adrenal glands to release a higher, much higher level or concentration of neurostress hormones into our bloodstream. Adrenaline, norepinephrine, cortisol, and many other molecules. These are very potent molecules. They do things. But it was never supposed to be normalized or sustained at that level. If it is, which is clearly occurring these days in an almost progressive manner over the last few decades, especially, if that stress response neurohormonal state level sustained for any length of time, it is degenerative. Okay. And I don't just mean in a broad concept. Anatomically, neurologically, at the synaptic and structural level, it is degenerative. And it also does things to our processor, right? The brain, if that is sustained. And I think we want to spend a moment just to explain what those changes are. Because I understand this at a personal level. You understand this at a personal level. I think most people, if they're being honest with themselves, can probably relate. If they have the insight and the humility to look at our own patterns, we can go, yeah, that actually makes sense, because it tends to always be true. So what is happening? It doesn't necessarily matter how that became our normal. There's lots of ways, right? Family trauma, abuse, neglect, relationships, just a deep anxiety or insecurity, our approach, our personality structure, all these things are connected in how we affect ourselves in a moment by moment daily experience. Our nervous system was built. It wasn't born. About 10% of who we are is innate, right? We call that predisposition, genetics, but we are all still so malleable at that young age that it is about what happens next that determines a million different ways that could go from that point moving forwards. When we talk about our nervous system, let's think of it as a complex system of roads.
Yes.
Those roads were built on demand. We have a system in our nervous system, a set of resources and mechanisms we call neuroplasticity. I call it the road workers. This was what built all these pathways. Why would they have reinforced one pathway versus another? Why would they put a dirt road going this way and a 5-lane highway going this way? The instructions that are given to the workers have to do with how and where the bandwidth of our awareness is invested. So is it being invested in that subconscious external flowing with a part of our environment, or not so much? That's just instinct. We all have it. And during that formative build, which is mostly pre-adolescent or early adolescent, that was about 95% of when those roads were being built. The patterns that we were experiencing, most of which we don't have any control over when we're that young, are the instructions to those workers to reinforce different patterns of instinct, perspective, response patterns, emotional patterns. All this is being coded in, and that can continue, right? Just that malleability wasn't just when we were very young. That neuroplasticity, yes, it's a little less as we get older, and it levels out around 25. And then it's supposed to continue at that level for the most of our rest of our life so that we can adapt that formative build through our emotional maturation process of our experiences, growing and evolving and adapting to hopefully become increasingly efficient creatures. But what if that initial build reinforced to a certain degree roads or instincts that, while probably totally understandable at the times that they were being felt, you don't really have the opportunity to change all the patterns around you and what that feels like. If we, for whatever reason, have developed too much of a normalcy or a comfortability or a preferential investment pattern of being in here, in our head, apart from, that's just an instinctive response. But if it becomes ingrained, then we are set up for
really hard times.
Because depression, anxiety, OCD, just on the mood side of things, that's where that comes from. When you add in the physical, this is controlling the physical. It's controlling the neurohormonal state. And it turns out, and we actually figured this out from ketamine over the last 15-ish years, that malleability that we were supposed to have so that we could go back as we got older and adjust these roads so that they were more adaptive and effective for us, we can lose it. And it's quite ironic how that occurs. It turns out that stress response to neurohormonal level at a receptor level in the brain turns off neuroplasticity. So the very workforce we would need, even if we had the best therapist and psychiatrist and pain management doctor and neurologist and life coach and new support system and willingness, motivation, time, bandwidth, and courage to try to invest our awareness differently and build something new, very workforce that would actually do that at an infrastructural level has been on strike the entire time.
Yeah.
And it doesn't come back until the stress response fully de-escalates, which it's not going to, because nothing's really changing. This is the setup. It looks like, if you look at the numbers, when someone actually takes the time to get to know a patient, you always see, and it's very unfortunate, but it does create a hypersensitized processing in three major ways. Number one, when you've lost the neuroplasticity, we can't really change much. Number two, we have totally normalized at an instinctive level that in here is who we are. It's a very internal sense of self, not an interactive or more of a communion with our environmental stimuli and the people, places, things, objects, living and unliving situations and experiences of daily life. This is what has become normalized to feel comfortable, safe. Our tendency to focus all of our awareness inside us, which I would say is our body as well, is normal to us. That's our go-to move, especially if there's causalgia, right? You have an injury, you're in pain. That occurrence or that experience is now become our entire identity, right? And it can happen very quickly. It's just like every ounce of our suppressed emotional pain over a lifetime, the resentment of what we've missed out on, our fear, our anxiety, our insecurity, everything now becomes channeled in such an angsty, resentful, fearful way onto one little area of our body. There's something I say, I don't know if it's commonly said, but the way our nervous system operates is basically where we focus, we will feel.
Yeah. I understand that concept. When you distract yourself, sometimes you can forget about it, or at least it's not as intense. Focusing on it, it just starts.
It will magnify.
Yeah.
And that's the way our brain is supposed to work. I use the word bandwidth intentionally. It denotes a limited resource, right? So where it's invested, it's not going to be invested somewhere else. That's evolutionary, right? So you could prioritize certain stimuli over others so that there's intent to our awareness,
Right.
which is fine when you need to make sure that the lion looking at you over the stream has priority over the pretty flower on the grass at your feet. But it depends how we use it. If we're very internally preferential in thinking, and this is me, this is this bubble here, and it doesn't necessarily involve, or maybe preferentially doesn't really involve, feeling affected at an emotional level by that which is not in our control, right? Sort of creates this illusion of internal control and safety. That's what our ego defense structure does. Here suddenly is an occurrence where something has affected us and it's a negative effect, and it just, every ounce of our being is now in full trauma response, all in on that thing. And when you already have the setup for a sort of a hypersensitized or a larger than proportionally might be helpful for us investment of bandwidth internally pattern, that's what we see in folks that seem to develop CRPS. It's not on purpose, right? They have no control over that. None. And it's not their fault at all. And I think it's important that they understand that, right? This was an instinctive response. The other big thing is that sustained neurohormonal stress state seems to hypersensitize certain processing areas of our brain. We talk about an area of the brain a lot called the default mode network. Think of it as a clearinghouse, right? It's the checkpoint that all of the neurologic data from our whole body is coming through, and it decides, okay, 99.999% of the normal neurologic data of our body is not necessary to rise to the level of our awareness, because that would be distracting. So it's almost all supposed to be filtered out. That tendency to de-escalate neurologic data, we can see a switch kind of get flipped, right? Instead of deprioritizing physical data, it goes the other direction. It takes data that is not needed, like CRPS type 1. In other words, our foot's not in the fire, right? It never was. And yet the processor is experiencing it as if it was. Why? Because instead of deprioritizing that signal, it is over prioritizing it. The chronic stress response states that preempted or preceded the pain situation seem to set the stage for that switch to get flipped.
Set it all up for it. I completely understand. You just explained to me what I haven't been able to figure out for a long time, even just when you try so hard to get better and you don't get better. So for me, it was with my mental illness to start, that I would try so hard, all these different therapies and different therapists, and it was just who I was, is what I identified it as, like you said. And it was just me, and I wasn't going to get any better. And that was just how it was. And I found a lot of irony being diagnosed with the CRPS when it's described somewhat like my mental illness, is being on fire and being hypersensitive to the slightest touch. And it's just a reaction. I always likened it to, if you've ever seen the movie A Perfect Storm, in the end, with the storm at its worst, you can't get your head above water long enough to even take a breath. Your cognitive function is not there. You can't make choices. You can't filter information. You're reacting. And it's really survival mode, because everything is just so loud and so overwhelming. I had to learn how to sit with myself and ironically ride the wave until it subsided like a flare. To ride the wave and know you have to until it's ready to be done, it's going to come back. That's really hard. And I think that the first flare that you get is scary because it's huge, it's painful, it's right now. Sometimes there's no documented injury. I woke up with the flare spread into my foot, and I had an idea of what it was, so I just acted accordingly. But it's hard and it's scary when you don't know what's going on. It's that extreme and nobody can tell you. And that fear keeps you in that state. It's that cycle of unknown, scary unknown. And I think that's just the hardest thing is not knowing at the beginning. I've heard a couple people say that when they find out that they have CRPS and it's not really explained thoroughly or correctly to them, that they're almost not relieved. They wish they were still back in that point where they didn't know. We all can't be good at everything. I feel bad for people that it's not their area of expertise. They can't be expected to explain something that they really know extensively, but at the same time, it still significantly affects the patient, especially if it's the fifth doctor maybe this month that can't tell you or can't explain it to you. And just by talking to you, I've learned more and things, the contributing factors around everything and how they all tie together, just the mental and physical aspects of how important that treating that combination really is in this case, especially.
And based on my experience and yours, now that you're working with other people who share similar stories, it does give us insight into these patterns, and it's easier for us to understand because we're seeing it, we're involved in it. The individual who doesn't come from that background, as you described, is just in pain and they don't know why. The way healthcare is set up right now, it's so compartmentalized. And let's be clear, CRPS is especially type 1, is what we call a diagnosis of exclusion. Right? In other words, they've tried to find every other possible diagnosis, and when they can't, it's CRPS.
Right.
And then they start thinking about, all right, was there some sort of confirmatory aspect that we can, or tests or things like that we can look to hang the hat on? Meanwhile, that patient is just suffering and confused and scared and frustrated because no one can give them clear answers. And speaking from experience, this is actually the typical state that we normally see most of our patients, right? They've either don't know what's going on yet, and no one will give them clear answers, even a CRPS diagnosis, or they just got the diagnosis and they've done a little bit of work, or the doctor that gave it to them is, here's your diagnosis, but there's nothing I can do about it. Or the third category is they've had the diagnosis for a while, and a doctor, or in many cases, many doctors, have been trying many different things and nothing's working. And with each attempted therapeutic that isn't successful, that patient is becoming increasingly hopeless and scared and depressed and anxious and traumatized just from that process. And one of those states is typically where we see people at Neurorelief, right? That's where they start going, okay, I feel like I've either tried everything or no one's talking to me, so I'm going to try to do some of my own research and explore what might be outside the fact that I have the monthly appointment with my doctor who isn't telling me anything or can't help me. What does that look like? What is ketamine? How does that work? Why are we using it for this situation? Even beyond that, it's still just a tool, right? It's a tool. What are we going to do with it? And how that tool is utilized by those that are wielding it. What can a client do as this tool is being provided to them to optimize the benefit, the healing?
Yes, that healing is the most important part. Thank you so much for taking us today on a guided tour of the nervous system and explaining neuroplasticity to us. I hope some other warriors out there found some comfort in knowing that there's a reason why multiple treatments haven't responded, and there's also hope to be able to correct that in our own bodies. Thank you for joining us for part 1 with Dr. Austin Harris. Part 2 will be released on November 15th, in which Dr. Harris will answer all those questions. What is ketamine? Why are we using it for this situation? What does it look like at Neuro Relief? Again, November 15th is when that will be released. We are now approaching Awareness Month for CRPS. Please help us to get awareness out there for the month of November. If you would like to support the foundation or the podcast, please text CWF podcast to 53555. Our support groups for November will be on the 2nd, 13th, and 30th. On the 13th, we will have Dr. Jay Kumar from episode 15 as our guest resource. There's still plenty of time to sign up, so don't miss out on those opportunities. As always, it has been a pleasure, and be safe and happy haunting.